Good day, everyone. The topic that we're going to discuss is about colorectal cancer. And this is the outline of this topic. Colorectal cancer is the third most prevalent cancer worldwide, with 1.4 million affected, and it is responsible for 935,000 deaths, second to lung cancer in 2020. In the Philippines, colorectal cancer ranks third among the leading causes of cancers and cancer deaths. It is the second most frequent cancer in males, next to lung cancer, and also second in females, next to breast cancer. This pie graph shows that the majority of colorectal cancer is of the sporadic type, arising from the average risk individuals and accounts to about 75 to 80% of all colorectal cancer cases, and roughly 20% of the colorectal cancer cases are of the familial type. And if you translate the incidence rates to the number of cases in the Philippines based on the Globocan estimates of the World Health Organization, of these 17,364 colorectal cancer patients in 2020, 13,891 colorectal cancer are of the sporadic type and 3,472 colorectal cancer patients are of the familial type. This third most common cancer have a median survival of 24 months with all stages combined. Majority are colon cancer, roughly 60 to 70%, and rectal cancer to about 30 to 40%, with colon having both a better overall 5 and 10-year survival compared to rectal cancer. The majority of colorectal cancers diagnosed in our country are stage 3 or in the advanced stage. The 5-year survival of this stage is lower when compared to an early stage of colorectal cancer. With all stage combined, rectal cancer has a low 5 and 10-year survival compared to colon cancer. Colorectal cancer has a high survival rate with a 5-year survival of 91.4% if the disease is diagnosed while still localized or confined to the wall of the bowel, but only 66.1% for regional disease or those with lymph node involvement, and only 8.5% if distant metastases are present. The adenomatous polyp cancer sequence explains the pathogenesis of colorectal cancer. The stages of colorectal cancer is determined by the depth of tumor penetration, lymph node involvement or metastasis, and distant organ spread or metastasis. This slide clearly shows the inward invasion of cancer starting from the mucosa, muscularis mucosa, submucosa, muscle layer, and serosa. To simplify the complicated staging nomenclature, localized disease is the stage where cancer is only confined within the bowel wall with no lymph node and distant organ spread. Regional disease is when the cancer has spread through the bowel wall and the regional lymph nodes. And lastly, systemic disease is defined as the stage where there is evidence of distal organ spread. The management of both colon cancer and rectal cancer involves a diligent history and physical examination, with colonoscopy and biopsy to confirm the diagnosis and rule out other synchronous lesions within the colon. The tumor marker carcinoembryonic antigen or CEA produced by the cancer is requested not for diagnosis but for prognostication and surveillance purposes. A careful cardiopulmonary risk assessment to evaluate the patient's physiologic and functional status to uncover comorbidities that may have a negative impact on surgical outcome. Preoperative or clinical staging for colon cancer involves identifying the T, the N, and the M status with the use of the chest and abdominopelvic CT scan. For rectal cancer, pelvic MRI or endorectal ultrasound assesses the local extent of involvement as the rectum is confined within the pelvis. The chest abdominopelvic CT scan assesses the distant and systemic spread. The value of arriving at a precise preoperative stage and with the patient's physiologic and functional status as well as comorbidities will dictate the treatment plan. If potentially curative but with big bulky tumors, a neoadjuvant treatment will be considered, followed by surgery. However, if resectable, then an upfront or surgery first approach is considered. The pathogenesis of colorectal cancer involves genetic mutations of the tumor suppressor genes APC, the oncogene KRAS, and the mismatch repair genes. These mutations will result to a phenotypic manifestation of the adenomatous polyp which increases in size over the span of 10 years and develop carcinoma. Germline and somatic mutations are the two types of genetic mutations that differ in their origin, inheritance, and impact to the body. Germline mutations occur in the sperm or eggs and are present at conception. The somatic mutation occurs in the body cells after conception. This slide shows the genes involved in germline mutation, the adenomatous polyposis coli or APC gene leading to the autosomal dominant familial adenomatous polyposis, and the mismatch repair genes or the MMR genes leading to the hereditary non-polyposis colorectal cancer or the Lynch syndrome. For patients with hereditary colorectal cancer, the influence of the environmental factors is small compared with the power of the underlying mutations. Thus, the risk of developing colorectal cancer is higher in hereditary conditions, with FAP patients developing colorectal cancer in 100% of the time and HNPCC patients developing colorectal cancer in 85% of cases. Patients affected by FAP is diagnosed with more than 100 adenomas within the colon, often manifesting as diarrhea. All of these patients will develop colorectal cancer by reaching the age of 39 years. Thus, once diagnosed, a prophylactic surgery should be offered to these patients, that is to remove the entire colon and rectum, or what we call total proctocolectomy, with or without reconstruction of intestinal continuity. It is of note that there are variants of FAP, namely Gardner syndrome manifesting with colonic polyposis with osteomas, soft tissue desmoids, and cutaneous lesions. Second is the Turcot syndrome manifesting as colonic polyposis with central nervous system tumors. On colonoscopy, patients are suspected to have FAP if more than 100 polyps are seen on colonoscopy. Patients with hereditary non-polyposis colorectal cancer involves mutation of the mismatch repair genes that fails to identify the mismatch base pairing. 80% of patients develop early colorectal cancer at a mean age of 45 years. It often involves the colon that is proximal to the splenic flexure, namely the ascending and the transverse colon. It is also associated with synchronous and metachronous lesions. Lynch 1 manifests as purely colon cancer, while Lynch 2 involves extracolonic cancers. Thus, once diagnosed, a total colectomy removing the entire colon is the recommended surgery. Amsterdam criteria is the one we use to clinically diagnose patients suspected to have HNPCC. Doing a family pedigree in our history helps us to map out family relationships and medical history to help identify the red flags of familial type of colorectal cancer. Of treatment for colon and rectal cancer is surgical oncologic resection, with the choice of the resection is based on number 1, location of the tumor within the colorectal region. Number 2, exclusion of family cancer syndromes with FAP and HNPCC are managed with total proctocolectomy and total colectomy respectively. Number 3, the extent of the disease, where T4 tumors or those invading adjacent organs will entail en bloc removal of the segment of the colon and the adjacent organ. And number 4 is the patient's operative risk assessment, where the physiologic and functional status as well as comorbidities will also be a big factor to determine the type of surgery. Definitive resection in only in good risk patients. This shows the common surgical oncologic colon resections. The final histopathologic results of the resected specimen determines the final stage of the patient. Those with evidences of lymph node involvement or metastasis are stage 3 patients, are the ones who will require adjuvant or postoperative chemotherapy. Radiation treatment has no role in colon cancer treatment. The type of rectal cancer surgery will depend on the location of the tumor. Upper rectal cancer are tumors situated within 11 to 15 centimeters from the anal verge or anal opening and are managed by doing anterior resection with anastomosis of the colon and the distal middle rectum. Middle rectal cancers are situated above the levators up to up to 10 to 11 centimeters and are removed by low anterior resection with colon and distal rectoanal anastomosis. Low rectal cancers involves the rectum below the levators, thus are managed by an abdominoperineal resection or the Miles operation that is removing the entire rectum with the patient having a permanent colostomy. With the goal of arriving at an accurate preoperative stage of the disease, rectal cancer evaluation requires a pelvic MRI or an endorectal ultrasound to determine the T and the N status of the rectal cancer, which is confined within the pelvis. Chest and abdominopelvic CT scan evaluates the systemic spread of the disease. Surgery for upper and middle rectal cancers, the anterior and the low anterior resections are considered sphincter saving procedures because it allows restoration of intestinal continuity, thus the patient can still defecate through the anus after the surgery. This is in contrast with low rectal cancers where the tumor is below the levators, where the muscle that is responsible for controlling the continence is involved, thus it is removed via the abdominoperineal resection, resulting to removal of the entire anus and the rectum with a permanent colostomy. No restoration of intestinal continuity is done. The abdominoperineal resection or the Miles operation was introduced by Sir William Ernest Miles and had used to be the standard of surgery for rectal cancer regardless of the location before the introduction of the sphincter saving procedures. This shows the two phases of the APR with eventual removal of the entire anus and rectum with closure of the perineal wound and an end colostomy. We were taught that cancers spread to either the bowel wall, the lymphatics, hematogenous, or through implantation or seedings when tumor cells break away and disseminate within the peritoneal cavity. The last will be the spreading through the mesorectum. This mesorectal spread is one of the major reasons why the 5 and 10-year survival of rectal cancer is lower than that with the colon cancer, because removal of the rectum within the confined bony pelvis makes the surgery more challenging, having the potential to leave behind the mesorectum that may contain the remnants of the cancer, thus a higher local recurrence and difficulty in achieving an R0 resection. To address the potential mesorectum being left behind, refinements in the surgical technique using a precise sharp dissection and removing the entire mesorectum down to the levators became the gold standard in rectal cancer surgery, which we now call total mesorectal excision or TME. Total mesorectal excision will lead to a complete removal of the mesorectum down to the levators. The resected specimen is now being evaluated for the completeness of the mesorectal excision by applying a dark ink into the mesorectum and cutting it transversely, where the ink portion would now represent as the circumferential resection margin or CRM, which is the one we evaluate in the preoperative staging process, that if cancer has reached this area, patients are subjected to neoadjuvant chemoradiation to decrease the tumor so that during surgery, the CRM will be free of this tumor, thereby achieving an R0 resection margin. This shows the resected rectum being evaluated of its CRM, because a CRM that is free of tumor has a lower risk for recurrence. The development of colorectal cancer from an adenomatous polyp takes around 10 to 15 years. This prolonged development gives us the opportunity to detect pre-malignant lesions or early cancers through the colorectal cancer screening, thus can prevent colorectal cancer development or may potentially cure colorectal cancer if managed at an early stage. Since majority of colorectal cancer will affect the general population that belong to the average risk, namely those less than 50 years old, no history of polyps, no family history of colorectal cancer, and no history of inflammatory bowel disease. This population will be the target for screening programs to detect polyps and colorectal cancer. In a joint guideline from the American Cancer Society, the U.S. Multi-Society Task Force on Colorectal Cancer, and the American College of Radiology categorized the different multiple testing options into fecal tests and the structural exams. The fecal or stool tests are those that primarily detect cancer, where they use bleeding as a surrogate marker for colorectal cancer. The structural exams detects the adenomatous polyps and cancer. The U.S. Multi-Specialty Task Force divided these different testing options into order of priority. Tier 1 options, which includes colonoscopy and FIT, Tier 2 and Tier 3 options. These stool-based screening tests are performed annually based on the evidence for achieving its full potential. And these are the different structural exams with its frequency. Any initial test that turns out positive should undergo a colonoscopy, since it is considered the gold standard for colorectal cancer screening. colonoscopy is considered the gold standard because it has the advantage of early intervention of a potentially cancerous polyp. With the successful removal of a potentially cancerous polyp, it disrupts and breaks the cycle of cancerous transformation. Thank you for listening.